Morning, folks. As Krupa mentioned, I'm Shireen Payton. I'm the Division Director of Community Collaboration at the Kenneth Young Center, and I'm going to turn off my video as I go through the slides so I don't distract myself. Okay, so just a little bit about the Northwest Suburban Community Northwest Suburban Comprehensive Addiction and Recovery Act. It's a grant that we have from the federal government, and it's through the Elk Grove Police Department, through the Elk Grove Village Cares Department. So it's a trio of organizations, the Elk Grove Village Cares, Live for Lolly, and Kenneth Young Center. The three of us administer this grant through the Northwest Suburban Cook County area in the Chicagoland area. So the federal grant is called the First Responders Comprehensive Addiction and Recovery Act, or FR-CARA, and the purpose of it is to allow, train, and provide resources to first responders and members of other key community sectors to administer Narcan, also establish processes and protocols, mechanisms for referral and appropriate treatment to appropriate treatment and recovery communities, and the grant comes from the Substance Abuse and Mental Health Services Administration, or SAMHSA. So the Northwest Suburban CARA Project, or sometimes we just refer to it as CARA, as I mentioned, the lead organization is the Elk Grove Village Police Department, and the subawards, as I mentioned, are KYC, or Kenneth Young Center, and Live for Lolly. The municipalities in the area, in the Northwest Suburban area that we're targeting, are the villages of Elk Grove, Arlington Heights, Schaumburg, Rolling Meadows, Des Plaines, Palatine, Prospect Heights, Mount Prospect, and Hoffman Estates. So our goal is for those police departments 100% to carry and administer the life-saving reversal drug Narcan, or naloxone, and then also within the targeted Northwest Suburban area to work with other folks in the area just to train them on the use of naloxone or Narcan. And the staff that's working on the Northwest CARA group would be, in Elk Grove Village, would be the Deputy Chief of Police, Michael Gaspari. At Kenneth Young Center, it's myself as the Division Director. I'm the project coordinator for the overall CARA project. And Daryl Pass is the Manager of Recovery here at Kenneth Young Center and his team. And then Laura Fry, the Executive Director at Live for Lolly, and her team. So why do we have a Northwest CARA? As I mentioned, why are we targeting the 9 towns? Because 6 out of the 9 towns had a combined total of 98 overdose reversals in the past year prior to us applying for the grant. And we also know through other efforts across the country that having efforts such as a Northwest CARA, it can help to reduce crime and increases a person's use of substance seeking supportive services. It increases community engagement. It also increases community partnership. So we know that these type of efforts overall helps folks in their recovery seeking activities or their recovery seeking behaviors. So here's some data just in the Cook County, which again is the county that we reside in. And this slide is will also be made available through the recording of this presentation, so we're not going to go over the data for the sake of time. And again, our goal is for 100% of law enforcement to carry and have access to naloxone by 2023. And because of cost, we're looking at the nasal version of it. And for community providers, we do have the vials and the needle version. So some of our objectives are to conduct 20 community education events within a year, train 2 villages and first responders on naloxone, create and maintain a community resource guide that's available online, distribute 24,000 naloxone kits to community members, including businesses as well as individuals, and then also conduct overdose prevention education in all 9 of the targeted villages, and certify 5 organizations as naloxone trainers, and then also train 300 unduplicated individuals annually. And the strategies that we use are, and here's Mike Gaspari demonstrating how you can make a naloxone kit as part of your other life-saving devices that you have throughout your building. So we make naloxone available. We train people on the information of our Good Samaritan law within the state of Illinois. We provide the resources on safety around licit and illicit drugs as the terminology used by the federal government. We help people to establish the process and protocol around naloxone use within their organization. And then also we work with our community advisory council and coalition, the Communities for Positive Youth Development, but we also help folks who have their own community coalitions or advisory councils or recovery councils, and how to have naloxone and Narcan training be a part of their council work that they do. So as part of the efforts that we do with the CARA grant by SAMHSA, we are required to use FDA-approved overdose reversal medication. So we are using naloxone or Narcan. And again, with this grant, in order to be fiscally responsible, we're using the most economically available with the dollars that we have. So that's why we're only using nasal and the vial, the injection version. I know that there's the auto injector that's available, but that is cost prohibitive for us at this time. But that is something that is also available out there for folks. So if you are interested in training or ordering naloxone and you live in the Northwest Suburban Cook County of Illinois area, please email me or give me a call, or you can send me a text. And if you qualify within the service area that's mentioned, you can contact us in order to schedule a training or to receive supplies, especially if you're part of any of those 9 villages or that Northwest Suburban Cook area. And again, the funding is provided by SAMHSA, and I thank you all for your time and enjoy your webinar. And I'm going to now stop sharing, and I will turn it over to Laura, our partner.
Good morning. Let me get my video on. Good morning, everyone. I'm sorry, but we had to make a little bit of a doctor scramble today, so I was a little off balance, but not so much. I'm going to share my screen. I really am going to share my screen, I promise. So we are going to talk today about one of my favorite topics, and that is harm reduction. I think I will turn my camera off so as not to distract myself, much like Shireen, that is easily done. Towards the end of this presentation, the last half hour or 45 minutes, Dr. David Kushner from Brightside Clinic will be joining me, and he will talk about medication-assisted therapy for opioid and alcohol use disorder. So I wanna start this out by asking all of you, what are your beliefs about harm reduction? What do you think when you hear the words harm reduction? What does that mean to you? There's no wrong answers. There's an awful lot of right answers, and absolutely no judgment. It just is always interesting to see what people think about harm reduction. So just drop your thoughts, random thoughts, free speech into the chat box, and I'd love to be able to take a look at what your thoughts are. Harm Reduction 101. I also want to share a little personal story. I have grown in my 8 years with Live for Lolly from being someone who threw out my son's naloxone and broke all of his syringes because I thought that was going to stop him from using drugs, to someone who now carries safe and clean supplies in my car at all times for people who need them. And what I've learned is that when we know better, we do better. So the definition of harm reduction by the Harm Reduction Coalition is that harm reduction is a set of practical strategies. And these practical strategies reduce the negative consequences of drug use. It incorporates a huge spectrum of strategies, everything from safer use to recovery and everything in between, with the goal of meeting people where they are at, not defining their space for them, but letting them tell us where they're at and what they need. We address conditions of use, the risks and benefits, and how to do so safer. A little bit of history on the harm reduction movement. The UK started prescribing heroin in a medical setting in the 20s. In the 80s, when we saw the HIV and AIDS epidemic take hold, syringe exchanges and harm reduction really came to the forefront, especially in Europe, Canada, Australia. Harm reduction continued to expand during the 80s and the 90s. And in 96, there were regional networks formed all over the world. Krupa, I'm wondering if there were any good ideas thrown into the chat box of what people think harm reduction is.
Yeah, really great question. Anna, I would love to say people's names, and I apologize if I mispronounce anybody's names. But Anna had said being treated as a human being with dignity, agency, and choice. Anna also added giving a space free of shame and judgment.
Oh, that's beautiful.
Paige shared that they love harm reduction and that they wish everyone did and that it was completely funded everywhere.
I'm with you, sister.
Yes, and then Amber also had a really great response saying harm reduction means prioritizing individual and collective safety and wellness over ideological values. It means intervening when established infrastructure fails.
Wow, that is awesome. Krupa, I know this is a little off-center, but is there any way to copy people's comments and save them? Because I would like to use some of those if I could as sound bites, because that is beautiful.
Yes, most definitely. The chat will be saved, and
Awesome.
I'll make sure that you get a copy of these responses.
Thank you, everybody. I see that I am preaching to my people, and that is awesome, because as I'm sure many of you deal with daily, not everybody is on the same page when it comes to harm reduction and drug use, and it is a constant source of defending and negotiating. So what are some of the general goals of harm reduction with people who use drugs? We want to reduce the spread of bloodborne infections. We have seen in communities when syringe exchange is introduced, the data shows us that the rate of hepatitis C and HIV drop. And we have seen that happen since 1983, and the first syringe exchange opened in San Francisco. We know that when we give people safe and sterile and clean supplies, and they use them and don't share them, bloodborne infections drop. Risky drug use. Substance use disorder literally hijacks the brain, and when this drive, this need for the substance takes over, it doesn't matter if the syringe is found in a gutter or in a garbage can or in an empty lot, it will be used. So that's risky drug use. Harm reduction also prevents drug overdose deaths. Since March, just in one of our mobile outreach locations, we have given out over 350 doses of naloxone, and that's just in one location. So harm reduction prevents overdose death. It gives honest drug education. What are the risks and benefits of drug use? And what are some other options? And I like to say the biggest thing that we do when we're out doing harm reduction in the community is connection. We connect people with services, with treatment, with housing, with medical care, with mental health care. It is all about connection, meeting people where they're at, and meeting them with love, care, and compassion. No judgment, no shoulds, no need to. We treat people with dignity and humanely, with no judgment and no hidden agenda. The term harm reduction definitely indicates that drugs can cause real harms, and they do. The harms can be physical, they can be mental, there's economic harms, there's social harms, familial harms, legal harms, harms to not only the individual who's using substances, but to their family. That extends out to the community and to society as a whole. But harms don't have to be an inevitable consequence of drug use. The harms can be prevented or reduced through a range of strategies that we're going to discuss. Some of our common harm reduction strategies, abstaining from substance use. A misnomer is that harm reduction does not believe in abstinence. Abstinence is a harm reduction strategy. Use moderation. Some people can take their use disorder and make it moderate drinking or moderate substance use. Medication-assisted recovery, using medications for opioid use disorder, using medications for alcohol use disorder, and other medically assisted recovery systems. Needle and syringe exchange, distribution of information. And when I say distributing information, we have flyers from our health department that talks about rotating veins and teaching our people who use IV drugs the importance of not using the same area and teaching them why that's important. Peer outreach. Most of the harm reduction organizations and syringe exchange locations that I know have peer recovery support specialists that work them. And being a peer, being someone who has potentially gotten out of this risky drug behavior is sometimes exactly what an individual needs to see that there is hope. People do get out. Safe consumption facilities. That was something 10 years ago that I would have very righteously on my soapbox argued about, that I now fully believe in. If we bring people into a safe area that is sterile and clean, surrounded by people who can help with connection and services, that's all good. Crack cocaine kits. I have very recently come under fire about handing out crack kits. And what does that have to do with stopping the spread of disease? I am a former crack user, so I can speak from experience that when you smoke crack in a crack pipe, lips become dry, they become burned, they open up, there's cracks in the lips, and whenever there is an opening, like a crack in your lip where you're bleeding from, you're not only passing on whatever it is you have when you share your pipe, but you're taking back in whatever anyone else has. So we always encourage our people to use their own pipe and either have separate mouthpieces if they have to use the pipe piece together, but to always use their own mouthpiece. Drug policy reform, working on ending the war on drugs. There has been a lot of legislation, and we'll talk about that a little later, that all of our harm reduction organizations in the country have worked on bringing about drug policy reform. And absolutely naloxone kits. We give out thousands annually. Naloxone, if there are people who don't know what that is, brand name Narcan, reverses opioid overdose. And the data shows us that when we saturate communities and we train lay people on how to recognize and reverse an overdose, there is much less overdose death. So the basic concepts accepts that drug use is human, and it brings both harms and benefits. The caffeine that I take in on a daily basis is definitely a benefit, and it's definitely a drug. Substance use is a public health and human rights issue, not a criminal one. And harm reduction does not promote drug use or judge drug use as being good or bad. We remain morally neutral and non-coercive. If someone is open to talking about recovery options, we are definitely there to give them those options and make those connections. If they aren't, then they aren't. And that is a decision that they get to make. Sometimes stopping drug use is not realistic or desirable. And we have to recognize that as everyone's right. We provide practical strategies to reduce the risks and harms that come along with substance use. And no human should be denied access to services because they are a person who uses drugs. We like to help people see the cost and benefits. We provide accurate, science-driven, data-driven information. And harm reduction likes to promote and facilitate access to care. And that means any care, whether it's treatment for an abscess or care to get into recovery. We engage our friends who use drugs in a continuum of care. And quite honestly, this segment of population is usually excluded in that conversation. I have never liked attending a webinar or a conference where people read from slides, so I am not someone who does that. There are so many principles that come into play when we talk about harm reduction. We recognize that the reality of many people who use substances are rooted in poverty, class, racism, social isolation, trauma, mental health, sex-based discrimination, sexual orientation discrimination, and a whole host of social inequities that can affect people's vulnerability and lowers their protection of themselves. So what harm reduction does is accepts that for better or worse, drug use is part of our world. It has been since the beginning of time. We have to understand that substance use is complex and multifaceted. One person's story can resemble another person's story, but it's all individual. What we try to give people is quality of life, whether they're continuing to use substances or whether they are seeking recovery or anywhere in between. Quality of life, giving non-judgmental, non-coercive provision of services. If I had to sum this slide up, that's what it would be. Harm reduction calls for non-judgmental, non-coercive provision of services and resources to our friends who use substances. So why harm reduction? Humans have been looking for ways to alter their consciousness since we crawled out of the cave. We are always seeking. We are never going to have a drug-free society. It just isn't going to happen. And I can tell you that I would probably fight anyone who tried to take my caffeine away from me. That's how strongly I feel about that. Abstinence can have limitations for many people. And so often I've seen people just give up because that thought, I'm 22 years old and I will never again be able to have a drink in my life. Well, why don't we just work on today and not worry about never? Because never to someone is a very long time. And abstinence might just not be attainable. Enforcement, we have seen the limitations that does. Does incarceration and criminalizing substance use cure the problem? If it did, we wouldn't have a problem. People will continue to use substances, they will continue to get sick, and they will continue to die. But they don't have to. And how do we stop that? We stop that by reducing illness, reducing suffering, and reducing the harms that come to people who use substances. So for those of you out there, if you can use your chat box, I'd love to see some examples of what you think with a person who uses substances. What is a positive change? We oftentimes say that we recognize in our friends who use substances any positive change. Any positive change is change. So what are some positive changes that you might consider or that you have seen that would be harm reduction related? And Krupa, if there's any really good ones, just jump on in here with me.
Sure, sounds good. Let's see. So there's a lot happening, but Alex shared that refraining from driving while intoxicated. Christina saying that they love seeing when people start to identify their triggers and stressors around substance use. Rose said from moving from crack to marijuana. Emily said testing before using, accepting of resources or contact information. Demetrius is saying willing to even have a conversation about harm reduction.
Oh my gosh, I love you people. This is awesome.
Tina said safer use practices by getting clean needles. Anna's saying always have Narcan available. Paige says when you hear a client talking to others about clean kits. Peter saying moving away or getting away from dangerous peers. Mary says using in a safe place, which I think you mentioned something about using in clinics where it's safer or legally allowed for folks to use. And Rose also added no longer requiring abstinence to participate in programming.
Yes, absolutely. That one, and those are a lot of times the people that we pick up and offer services to when someone, and I can't stand this language, any of you who did my stigma and language webinar will be surprised when I say that, but when someone in sober living drops dirty and they're shown the door with no resources, what do you think's going to happen? That's just not even logical, and it's not humane, and yeah, we need to get away from that practice. Abstinence works for many people, but as individuals we should be allowed to decide what our recovery and what our program looks like.
So Laura, before we continue to the next section, we did have a question. Would this be a good time for me to share what this question was?
Sure.
So Wendy had asked that what is the difference between harm reduction and enabling?
Oh, that is such a complex, that is a webinar in and of itself. I personally have stricken the word enabling from my vernacular because it is not my decision to make with another human's substance use. So I don't think that enabling and harm reduction have a lot to do with each other. Does that make sense? I kind of would be curious to know, Wendy, what you mean by enabling, because a lot of people would consider giving someone a box full of clean syringes enabling their drug use. I mean, right? That's what I used to think. That's why I used to break my son's needles so that he wouldn't use, but that didn't stop him. So I kind of turn that language around and say that what giving out clean syringes enables is for someone to not get a disease. What naloxone enables is breathing. What a personal use crack pipe enables is not spreading disease. So I kind of take that word and I use it in a harm reduction way. And when you're a parent that's impacted by a child's drug use, that gives the story a whole different bend. So I don't want to appear that I'm not being sensitive. I lived that world. And it is such a fine line because we don't want to enable drug use.
Yeah, Wendy followed up a few seconds ago and shared that, and I think this might be corresponding to when you spoke something. I'm not sure exactly at what point if this was sent, but that is what Wendy said, that is what I think. I feel like it's saying, I'm okay with watching you kill yourself instead of helping you get better. I'm helping you get worse. And Wendy also added that she identifies as a recovering addict, also in 12-step recovery, and finds it hard.
Yeah, absolutely. I have a lot of friends and community partners that are in the 12-step community, and the 12-step community sometimes struggles with harm reduction. But what I've found is that when I show another human being that I care more about their life and their quality of life, that I care more about them using safely so that they don't get sick, so that when they make a change, they don't have a lifelong debilitating illness like hepatitis C that they now have to fight while also fighting to be in recovery. When we show that we love people without judgment, it plants a seed. You know, it plants a seed of, maybe I could do something differently. I'm going to go back to these people who never judged me, who cared about my physical well-being, and I'm going to talk to them now about recovery. And it's happened personally to me dozens of times.
Yeah,
I don't know if that makes any sense. And Wendy, I would love to talk to you offline. I'm not here, and I don't judge anyone about their negative feelings towards harm reduction, but I would like to be able to present facts and data about how harm reduction works. Does that make sense?
Yeah, Wendy hasn't replied back yet, but Wendy, we definitely encourage, I can share you Laura's email address. Everybody can have Laura's email address actually. If you'd like to further the conversation, which I definitely encourage. Laura, do you mind if I share another comment?
Oh, please.
Sabrina shared a personal experience stating that, quote unquote, if I didn't have a needle, I would share or use a dog vaccination needle. I got hepatitis C, and if I could have avoided that, I would have appreciated the support. Yeah.
Thank you so much for sharing that personal story. And it's those are the stories that we need to hear more of. When in the grips of the disease, I've known people that have used water out of a toilet bowl at a gas station to cook down their dope. And that is just inhumane. But, and you know, I probably will say this ad nauseum, 8 short years ago, I didn't believe this at all. So when we know better, we do better. So I just encourage people, I'm not trying to change anybody's mind or push my agenda. What I did is I read hours upon hours of studies all over the world where they've been doing this in the Netherlands and in Europe for many, many years. The Portugal model, what they're doing up in Vancouver. All of these people can't be wrong. And then you see the data. You can literally look at, this happened in Scott County in Indiana a few years ago. They had a huge rise in HIV. And Governor Pence, who is now our vice president, was a governor then, and he started allowing syringe exchange to try and get a handle on the HIV cases, and it worked. So look up Scott County. Is it okay to move on, Krupa?
Most definitely.
So I wanna talk about some myths and some beliefs. One of the myths is that harm reduction is opposed to abstinence. And that is where a lot of the conflict with some recovery communities has come into play. The fact is, abstinence is one strategy of harm reduction. But there is a vast continuum of possibilities. But abstinence is definitely one of many goals, and one that we support if it is right for that individual. Harm reduction encourages drug use. I can see how people would think that. Absolutely. But at its core, harm reduction is not for or against drug use. We don't seek to stop drug use unless that is the person's goal. But we also don't, we just meet people where they're at. We focus on supporting whatever an individual's efforts are to reduce the harm that they are having upon themselves from their drug use or any other risky behaviors. Getting people to stop using at the Shell gas station bathroom and use in a library. That's a positive change. It's a cleaner location. So we don't have an opinion on drug use. Not for or against. So I like to ask the question when I'm doing this in person, how many people put a seatbelt on when they got in their car today? When we encourage people or our children to wear a seatbelt, does that give them the okay to go out and drive recklessly? It's kind of the same theory. And do we encourage people to wash their hands after using the toilet? I don't think anybody says, ha, I'm not going to do it because I want to spread germs. And this is a little funny. Everybody needs a little chuckle. This is a wife employing harm reduction, right? I really wanted to eat 12 Oreos, but I just ate 6, and therefore I am dieting. One of the myths is that harm reduction has a laissez-faire, anything goes attitude. Whatever it is you want, you just do. But the truth is, we don't condone or condemn any behavior. We help an individual evaluate their own consequences of their behaviors, how they can reduce risky behaviors for a better outcome. And we try to help individuals see how their behavior and how their actions impact their family and their community at large. So this takes me back to my DARE days. Educating people about drugs will make people not want to use drugs. I started using substances when I was 12 years old, after we were given the book Go Ask Alice in 7th grade to read. I read that book and I wanted to try every single drug that girl had done in that book. That was not the intention that my 7th grade teacher had, but that was the effect it had on me. We definitely want to educate people about the risks involved, but people have been using drugs since about 4000 BC to cope with life and as a medical survival tactic. Comprehensive approaches to social crises are essential to reduce negative impact. For example, the AIDS crisis in the 80s, the civil rights movement. Showing a frying egg in a frying pan and telling children that this is their brain on drugs didn't work. DARE was defunded by the federal government because its approach was based on criminality and not health. Fear tactics don't work. Humans have curious minds, and fear tactics just don't work. I attended a wake a few years ago of someone in our community that died of an overdose. There were a lot of kids there, late teens, early 20s. And right there in the funeral home, someone overdosed in the bathroom. So obviously the fear tactic of seeing a friend's body in a casket was not enough. And the stigma is more dangerous than I think just about any drug out there, because stigma breeds silence. Clean and sober should only be achieved and sustained without medication or mind-altering substances. When I stopped using alcohol in a negative way, I went to AA daily for a long time. Definitely helped me save myself. However, what I've also seen is people kicked out of meetings because they were on a medication that was helping with their opioid use disorder. And that really shocked me, that people would be asked to leave a meeting because they're on Suboxone or because they're on methadone. That is what led me to become a Smart Recovery facilitator and actually be the co-coordinator of Smart Recovery in the state of Illinois. The fact that what people are hearing often is that Matt is replacing one drug for another, cheating, you're not really sober, you're not in recovery. Damning people for seeking medical help for a disease. It's just not right. We know that ASAM, NIDA, National Institute of Health, SAMHSA, who promote substance use disorder as a biopsychosocial disease. It's best treated with medication assistance, behavioral health counseling, social support, familial support. And medication should be left up to a patient and doctor. That's what Bill W. said. I still have my blue book. There is only one way to recover from substance use disorder. Can you think of any other disease? And maybe there is one out there, but can you think of any other disease where there's only one way to treat it or to reduce harms from a disease? You look at any other chronic relapsing remitting disease, which substance use disorder is defined as, diabetes, multiple different ways to manage and treat diabetes, cancer. There's more chemotherapy treatments out there than we even have time to list. So why is it that substance use disorder is approached as this is the only way to go? Why is it the only disease where one group of people or an individual can shame another person because they aren't following their pathway? I only know that my path of recovery works for me. I can share my story in first person as my story, but I can't tell someone else they have to do it my way, because there's so many different pathways to recovery. Relapse is failure. This one really bothers me because I have seen so many people have a reoccurrence. This is a chronic, relapsing, remitting disease. And it becomes a moral failing. It becomes a character flaw. Someone could have 10 years of continued recovery, and they have one slip and they've lost that 10 years. The people that I work with, that I mentor, I call it a reoccurrence or a slip. That doesn't mean that you have lost all of this recovery time and all of these recovery resources that you've built up. It's a reoccurrence. Let's take everything we've learned in these past 10 years of your recovery, figure out what worked, figure out what didn't, and continue forward. We're not walking backwards, we're walking forward. And I think this might address some of the concerns about harm reduction enabling. Providing this outreach, clean needles, Narcan, encourages use and keeps people sick. There is not one person I currently know who is using substances problematically that enjoys where they're at. There is not one person I know who wakes up one day and says, I think I'm going to shoot a hot shot and overdose because I know my mom has Narcan. Doesn't happen, doesn't exist. Everything that I had been told in my childhood, throughout my own substance use, is that drug use is bad. It is bad, and people who use drugs are bad. Back when my son was an IV heroin user, harm reduction was controversial. It's still very controversial. But what I started connecting is every time I got in my car and put my seatbelt on, I was practicing harm reduction. Every time I brushed my teeth, every time I got my flu vaccine, every time I used disinfectant, every time I took one of my kids to get vaccinated, that was all harm reduction. So why should that not extend to this population of people who use substances? And I learned all of this from my dear, dear friend, Dan Bigg at Chicago Recovery Alliance, who's been doing harm reduction outreach since the very early 90s. Dan started meeting people who use drugs where they're at, connecting them with help if they wanted it, and teaching them a safer way. becoming a public health educator, developing our naloxone program, developing our harm reduction and mobile outreach program has not been met with complete support. There's been a lot of criticism, a lot of concern, but I always have science and data behind me, and you can't change that. You can't change the facts. Any questions through that section, Kripa?
Yes, we do have a question. Anne had asked, so quote unquote, I am wondering, as a former addictions registered nurse, are there now treatment programs in the area that are on board with harm reduction? It is radically different from how we did 12 steps treatment. It was based on total abstinence.
Yeah, what I've seen happen the last few years is an acceptance of medication for opioid use disorder. Most treatment facilities are now allowing people that are on Suboxone. Methadone is a little trickier because it's a daily dose system currently, which don't get me started on that. But I totally understand if you're if you're running a recovery home where you have 12 people, you can't have one person who is still using IV drugs, right? So you have to consider the whole. But what I would like to see people do is to engage that person with a peer support or a recovery coach that might be able to help them and connect them with services instead of just showing people the door. We have gotten a lot of interest in our mobile outreach unit coming to treatment facilities, coming to methadone clinics to practice harm reduction with their patients and clients. But it's tricky, and I totally hear what you're saying. And I don't have all the answers. That's for sure. We are a work in progress, and I learn just as much from people like yourself as I teach. I don't know that even really answered that, but I tried. Anything else, Krupp?
I don't see any other I do see one comment that I'd like to share, and I also then wanted to share something else that came to mind. So the comment is from Suzanne, who had shared that, quote unquote, had a friend asked to give their lead, and while sharing their story, they turned off the microphone when she started the part of her story where she is on methadone. So I think Suzanne is speaking to stigma and the real ramifications of it.
That is a damn shame. I'm sorry. She was so ashamed of being on methadone that she had to not say that. And you know what? That shame and that stigma keeps us sick. And we really need to, those of us that are in the treatment realm, those of us that are harm reductionists, in the medical field, we really need to call that out and make changes, because this isn't going away. And what the data tells us, I think, and don't quote me if I say the wrong percentage, but using medication-assisted therapy for opioid use disorder has about a 67% success rate. How can you dispute those numbers?
Yeah, most definitely. Anna followed up saying that it's important to me to note that MAT-OAT is now considered the gold standard of treatment medically, regardless of how a 12-step program feels about it. And Suzanne did follow up saying that the person who cut the mic in the story that she shared was a AA meeting chairperson.
Oh, it's so sad. Let's try to find ways that we can come together instead of battling each other and the people who are reaching out for help. It's causing harms. That in itself is harm reduction. I have about 40 more slides to get through, so I'm gonna keep going.
Sounds good.
So what are some practical strategies? Having syringe access and needle exchange programs. What we do know, especially here in Illinois, I know some people are not from Illinois, but I only have Illinois data. The last 5 years, Illinois has seen a 43% increase in hepatitis C. Currently, 1 in 3 IV substance users indicate they also have hep C. 1 in 3. A package of sterile syringes costs us about $3 to purchase. Hepatitis C treatment can be upwards of $120,000 or more for the cure. And it can have lifelong ramifications. So a bag of clean needles for $3 or lifelong treatment in the hundreds of thousands of dollars. Same thing with HIV and AIDS. So syringe access really not only spares lives, but it saves taxpayer money. Much more cost effective to give people safe supplies than to treat them on the back end. And for those of you that don't know, hepatitis C is a liver disease. Up until just recently, it was not curable. We now can cure hepatitis C, but it's costly. It's costly and there can be side effects. So why not prevent that? Harm reduction is prevention. Prevention for bloodborne pathogens that can cause a lifetime of health issues. And like I said, with the uptick in hepatitis C here in Illinois, most new cases of hepatitis C that we're seeing throughout the country are among people who inject drugs. And this is a frightening infographic. 1 in 7 people currently right now living with HIV are unaware that they have it. 1 in 7. Let that sink in. So a clean bag or box of needles could not only prevent the spread of disease, but save people's lives. AIDS, HIV is very livable. You can live with it. It takes a lot of regimented care, but you can live with HIV. When HIV goes to AIDS, there's really not much to do. And we could all prevent all of that, potentially, by treating people as human beings and giving them safe supplies. And yet, and I'm going to share this because I like being vulnerable. I've done a lot of studies with Brene Brown, and I like to embrace my vulnerability. There is still that tiny little voice in my head, and I squash it every time it comes up, but there's that tiny little voice that says, but if you just didn't start to begin with, we wouldn't have this problem. Anybody else ever have that little voice, or am I just so bad? I think that's human for those of us, especially parents who have children or siblings who have brothers and sisters that are people who have problematic drug use. That's so easy to say, why don't you just stop? Believe me, there is not one person that I work with who wouldn't like the easier way out to just stop. When drug use goes from social drug use to problematic drug use and people are hijacked by their substance, no one enjoys that. That is not fun. Not fun at all. So Dr. Kushner is going to come on probably in about 20 minutes, and he's going to talk about medications that are used for opioid use disorder. And like I said earlier, these medications show about a 67% success rate. And what happens in the brain with opioid use disorder is opioids flood the brain with dopamine. And dopamine is our feel-good chemical. Dopamine is what is released when we have a really good workout, or when we have sex, or for me, when I eat dark chocolate ice cream, dopamine in the brain. But when you are misusing opioids, the brain is a very smart but can be lazy organ. And the brain says, you know what, I don't need to do this anymore. I don't need to produce this chemical, so I'm going to stop. A brain cannot function without these chemicals, without dopamine, serotonin, melatonin. We don't function well without these chemicals. So what medications for opioid use disorder do is replace part of that opioid that's being misused so that the brain gets some dopamine. I like to compare it to the thyroid medicine I have to take every day because I don't have a thyroid. So my thyroid does not produce that chemical, so I have to replace it with a medication so that I can feel my optimal best. Same thing. I'm not a doctor, so I'm going to leave the heavy talk about this to Dr. Kushner. I don't know if anybody keeps up on the data, but we are going to have a record overdose death year this year. Combined with COVID, it's going to be devastating. Chicago just released data. They are currently double overdose deaths from this time last year. Where I live in Lake County, we are currently 23 overdose deaths above where we were at this time last year, with 20 pending and probable overdoses added to that. Everywhere in the country is being impacted by COVID-19. And substance use disorder is a disease of isolation. We have seen treatment centers either shut down altogether or drastically have to reduce the amount of clients they can take in. This is a perfect storm, and our friends who are out there suffering from the disease of substance use disorder are going to be very hard hit. And we just started seeing the first recorded fall of deaths since the early 90s. And then this pandemic hit, and it's going to turn everything on its head. So as you heard in our webinar last week, if you attended, naloxone, or brand name Narcan, is a drug that reverses opioid overdose. It reverses all opioid overdose, whether it's a Norco or whether it's fentanyl. Works very quickly. Lay people in the state of Illinois can have this and use it. There are 43 states in the country, as well as DC and Puerto Rico, that allow lay people to administer naloxone. It reverses opioid overdose in 30 seconds to 3 minutes and has zero effect if no opioids have been ingested. In one area of Lake County that we bring our mobile outreach to, and we've given out probably about 360 doses of naloxone. We have heard back from 5 participants that have come back and said that they've saved lives with that naloxone. That's a win. That's a harm reduction win. If you are a human, and I say this to everybody I encounter across the board, if you are a human and you encounter other humans in your day-to-day life, you should carry naloxone. So if any of you don't have it, reach out to Live for Lolly, reach out to Kenneth Young. We will get you naloxone. It is very empowering to come upon someone who is blue and be able to bring them back. Whether you have someone in your house that uses opioids, doesn't matter. Personally, I reversed a couple, a man and a woman, who were slumped over in their car at Lakewood Forest Preserve, which is right down the street from my house. I was hiking, I came out of my hike, and I saw 2 people slumped over in their car. My son has reversed an overdose in the parking lot of the Starbucks in McHenry. He came out with his coffee and he saw someone slumped over their steering wheel. You just never know. So arm yourself with the ability to save a life. So we know that opioids are central nervous system depressants. They, at high levels, slow down the breathing, and then breathing ceases. Naloxone, that's all it does. It knocks the opioid off and covers the receptors so it can't reattach. Something we started doing 2 years ago is handing out fentanyl test strips. It is just another harm reduction tool. It is not an exact science. We need a spectrometer for that, and I am happy to say that Chicago Recovery Alliance has a spectrometer. People can bring their substances there and have it tested. We have personally tested and found fentanyl in ketamine, MDMA, LSD, cocaine, and I had, yesterday I was speaking to a person who uses heroin, and they told me that they have not found pure heroin in several years. Fentanyl is being put into everything, and it is very deadly. So we started passing out fentanyl test strips so that people could test their supply and then adjust accordingly. Do people not use if they find fentanyl? Probably not. but they're armed with the knowledge they can use less, and they can be sure that the people around them have naloxone. And that's a positive change. Some lesser known treatments that are used around this area, not only pharmacological treatment, but we have detox, inpatient, outpatient, residential, mutual peer support groups, behavioral therapies. But what's the data telling us? There is a massive treatment gap. Out of 21.6 million people that needed treatment, only 2.3 received it. We need more treatment. I think all of us could agree on that. Some lesser known treatments that are used in many other places around the world, but not in the United States, ibogaine. It is a plant substance that is psychoactive and has been used in many other places around the world with great success. You can look up studies that were done on the MAP site, which is a multidisciplinary association for psychedelic studies. A lot of promise with ibogaine. Ayahuasca is the same thing. This is used in Peru, Costa Rica, South America, Brazil, and it is also a psychoactive drug that resets the brain. And ayahuasca is actually being looked at as a potential treatment for PTSD, depression, and trauma. Legal cannabis. Illinois is now a legal cannabis state. And what making it legal has done is allowed people to go into a dispensary and talk with someone about their medical conditions, their mental health conditions, and being given a product that won't, or that will help with these specific issues that they are dealing with and not make it worse. This is a very controversial topic. I have friends whose children have had cannabis psychosis, which is very scary. Lots of benefits, but not without issues as well. Safe consumption spaces, very controversial. But what we know with areas around the world that currently have safe consumption spaces, bottom line, overdose death is reduced. Infectious disease transmission is decreased. The number of people who ask for treatment or want to make positive changes in their current use pattern is increased. You look at the data for areas that have safe consumption sites, you don't see drug trafficking or crime or police calls going up where these facilities are located. And it reduces stigma, and stigma really is the culprit for keeping people in their disease. And I think someone earlier talked about treating people with dignity and kindness and compassion like you would any other human being who is struggling with a disease. So what does the outreach worker, so when we go out in our truck to various towns, what is it that we bring to harm reduction? We bring options. We have recovery coaches that help people work on the risks and the costs and the benefits of continuing in their use pattern or making changes. We offer case management. We keep in touch with these people. We schedule phone calls or regular meetings. We help with their needs, not just their substance needs. Last week, we were signing people up for Link. This week, we're going to start registering people to vote and helping people understand the importance of getting their vote out. Whatever the individual's need is, we will help them with it and connect them to who can help. This is and was such a big dream of mine. This is our mobile outreach truck that we take out on the road to help communities and individuals with substance use disorder. We currently spend one day in Lake County, one day in McHenry County, and we're adding a second McHenry County location in Woodstock. We are currently at 1 o'clock today, we will be in McHenry. By the end of the month, we're going to be in Woodstock. We're adding a location in Schaumburg, Evanston, and West Chicago, probably by the end of fall. And our mobile outreach does not just hand out crack pipes and syringes. We have typically a medical doctor who's an addiction specialist that is there with us. We have 2 to 4 recovery support specialists. We have a CADC. We have a social worker. And a grief specialist. We have our grief specialist there. So we try to cover anything that an individual might need. We also have resources, whatever county we're in for that county, resources to housing, resources to treatment, methadone and Suboxone clinics, doctors, and we have enough staff and volunteers every time we go out to be able to transport people to treatment. At our Lake County location, since we restarted in June, I think is when we started going back out, we have already physically transported 6 people to treatment. And, you know, that is, for me personally, the ultimate goal is to help people see their own value and want to make a positive change. Oh, and I said all this already. Look at that. We're also going to start offering HIV and Hep C testing. That's coming in the very near future. So when we're working with loved ones, we like to instill or help them see that these principles are important. Do no harm. Do no harm. Denial is more than a river. People don't respond well to punitive actions. We need to help people see what they need to do to take care of themselves. Sometimes people's behavior makes sense when we can figure out where it's coming from. Someone who experienced childhood trauma makes sense. People can make rational decisions even while they're using substances. Sometimes they just need guidance. And it's okay to be ambivalent. I was there. I was not only ambivalent, I was an awful human being who chased people out of their driveway with an aluminum bat because that's how I was going to solve my son's drug problem. Yeah, that didn't work so well. So how are you incorporating harm reduction into your personal and professional lives? Think outside of the box. It's not just about drugs. What are you doing? like to introduce my dear friend, Dr. David Kushner, who is an addiction medicine doctor at Brightside Clinic, one of our partners.
Hi there. Good morning. I'll start out by talking a little bit about medication treatment of opioid use disorder. Laura, I should ask you this. My own picture of myself is blocking some of the words, so I assume there's an ability to move that. Yep, got it. Sorry. We're good. Can you guys hear me okay?
Yep.
It's all good. You're perfect.
So the first question is, why would we use medications for opioid use disorder? Now, there are agonist and partial agonist medications that I'll talk about a little bit. Methadone and buprenorphine would be those agonist and partial agonists. And then there's antagonists. Most people are familiar with naltrexone. And using these for opioid use disorder and combining medication with psychosocial support is an excellent way to treat the disease. Now, agonist and partial agonist medications are indeed first line. This is highly evidence-based treatment. It's proven to impact patient-centered outcomes, and it's recommended as first-line treatment by many major societies that you see there. It's something that I've been doing for more than 5 years and have found it to be very, very successful in treatment. Choosing the ideal medication is important. Some patients respond better to one or the other. And I'm actually going to start over on the right side of the screen where we're talking about naltrexone. This one is an antagonist. This is similar to Narcan, honestly, which reverses overdoses, but this is a much lower dose, and it's a 30-day injection that you can give to do two things: to attempt to impact cravings. And while the impact on cravings is not as strong as methadone or buprenorphine, it does, in some patients, attenuate the cravings. Naltrexone is an interesting drug. We can use it in alcohol to take some of the desire out of drinking. They've even used this in pathologic gambling, sex addiction, and other types of addiction. And it works in the brain in the area where opioids cause release of dopamine, and dopamine is the pleasure chemical. And that could be the pleasure chemical from using drugs, can be the pleasure of gambling or eating even. They've used this in obesity. So it does work in that area where dopamine is released. If you inject someone with naltrexone and they try to use opioids, it will block them. It's kind of like having a 30-day Narcan aboard. So one would be perhaps disinclined to use opioids because any money they spend on them is likely a waste because they won't feel the effects. And ideally, it attenuates their desire to use in the first place. It can be referred to as Vivitrol, and we give that every 4-week injection. Importantly, you have to be off of opioids for 7 to 10 days, because if there were opioids on board, this would be like giving Narcan to someone who has opioids aboard, and it would immediately remove the opioids from the receptors and would throw someone into withdrawal. So the challenge using naltrexone is that you need to get 7 to 10 days off opioids completely. So if someone is dependent on opioids, you would need to taper them down or get them off and deal with the withdrawal symptoms without using methadone or buprenorphine, because those are in a way related to opioids. So if you were using those drugs, you would have to have them off of those medications for 7 to 10 days as well. And dealing with their symptoms for 7 to 10 days can be challenging because they will potentially have withdrawal symptoms. But if they have been detoxed somewhere and are completely off of opioids for 7 to 10 days, then it is a reasonable choice. So now moving to the left, there's methadone, which has been around for quite some time and is given to patients at a clinic. This would, in theory, help them with their cravings because it is going to the part of the brain that opioids, conventional opioids, would have gone to. So if someone was previously using heroin and now uses methadone, it will, in a way, satisfy the same itch, so to speak. And if you get the methadone dose right, and it takes time to build up to the ideal efficacious methadone dose, then you would impact cravings and desire to use. It's a liquid that you drink, and anytime after someone presents to a methadone clinic, they can be started immediately. Now, for some patients, it's a good thing that you go to a methadone clinic every day. That's the structure that someone needs, the accountability that one might need. And over time, after trust is built and a number of negative urines or certain behaviors have been achieved, outcomes have been achieved, then perhaps they'll give you a few days of dosing to take home where one would not need to go to the clinic every day. I think the first thing one could expect is getting their weekend doses to take home, and ultimately may get 1 or 2 weeks of doses if enough time has passed with enough negative urines. The problem, if it's a problem or challenge with methadone, is patients can use conventional opioids on top of methadone, and methadone does not block their action, where buprenorphine blocks the action. If one was taking buprenorphine, and we'll talk about that in a second, and then tried to use Norco or heroin or Percocet or fentanyl, for example, they likely wouldn't feel it, because buprenorphine, I explain it like, when you have an opioid receptor, think of that as a lock, and think of an opioid as the key that goes inside of the lock. When you use buprenorphine, it's as though you put the key in the lock and then break off the key so that no other keys can get into the lock. So that's how buprenorphine blocks the effects of other opioids. Whereas methadone does bind to the opioid receptor and give a desired effect and hopefully address the cravings. But for some who are inclined to use on top of methadone, they may use heroin on top of methadone or use pills on top of methadone, that would be additive in its effects. And so then you can get someone who is substantially intoxicated, if that's the term, by multiple drugs at the same time. I'm not suggesting that methadone is not an effective thing to do, but you can use on top of methadone. Now, moving to buprenorphine, we talked a little bit, and like methadone, the idea is to have withdrawal symptoms addressed and cravings attenuated or gone. So you can use both of these drugs when patients are in withdrawal, both methadone and buprenorphine. You can't use naltrexone unless you get 7 to 10 days. So if a patient gave up heroin today, at some point, 12 to 24 hours later, they would be in sufficient withdrawal to start buprenorphine. You don't need that withdrawal to begin methadone. The unique property of buprenorphine is that the opioid receptor inside of the body would rather have buprenorphine than any other opioid. So if there were 2 opioids coming in the system at the same time, where you have buprenorphine and then you have Norco, the buprenorphine will bind and the Norco will get rejected. So that is a good thing. However, if someone is presently under the influence of Norco or is under the influence of heroin and you start that buprenorphine too soon, it will kick that other opioid off of the receptor and cause withdrawal. That's why we need to wait 12 to 24 hours before starting buprenorphine. So a patient has to be in some degree of withdrawal. And I will often talk to them about withdrawal, and in almost everyone who's ever used pills, opioid pills, there have been days when they can't get it. And they know that feeling, whether it just be edginess or lethargy, irritability, nausea, diarrhea, typical withdrawal symptoms. And the same goes for heroin or fentanyl. There are days or periods of time when users cannot get their drug of choice and they go into withdrawal. So before starting buprenorphine, I have to explain to patients that you need to get in some degree of withdrawal for the buprenorphine to launch effectively. If you give it too soon and there is still heroin, fentanyl, hydrocodone, codeine, oxycodone in the system, it will immediately yank those off of the opioid receptor and throw a person into withdrawal. So it's important that a patient be honest with their prescriber and that we have good communication in the hours and days following induction with buprenorphine to make sure that it's timed appropriately. And again, methadone, you don't have to wait because that does bind the opioid receptor, but not in a way where it's so preferred that no other opioid can be around. And naltrexone, in a way similar to buprenorphine, binds the receptor and would kick off any other opioid that was around, and that's why you need 7 to 10 days for naltrexone. You need about 12 to 24 hours for buprenorphine, and methadone you can give right away. Methadone, you can use other opioids. Buprenorphine, you can try, but you won't feel them because the buprenorphine binds so tightly that no other opioid can get in there, and naltrexone blocks you completely. That's the sort of ABCs of medication treatment there. And just at the bottom of the slide, it just talks about with methadone, you schedule an intake at the methadone clinic and you can be started on treatment, and they will gradually titrate you up to a dose that's effective at controlling cravings. With buprenorphine, it's always challenging to figure out the exact dose to start someone on. You want to deal with their cravings, and they're going to come to you in withdrawal or soon be in withdrawal if they follow your instructions, and then you need the proper dose of buprenorphine to mitigate that withdrawal and get them comfortable quickly. And as I explained to patients that I prescribe buprenorphine, we want to find the lowest possible dose to control your cravings. There's really nothing to be gained by taking extra buprenorphine, and that's where the partial agonist label comes into play. And I explain this in the following way. If someone was taking oxycodone and they took one, they would feel something, unless they were very tolerant, where one no longer does anything. But let's assume that you find the dose where they would feel it. Let's say one Percocet or one 30 milligram oxycodone tablet, or two. If you take 4, you will feel significantly more effect. And if you take 6, you would feel even more effect. With buprenorphine, as you raise the dose, the effect increases, but then it levels off. So it very, very quickly gets to what we call cruising altitude, and you don't get anything more from taking additional doses, which I think is a good thing. Because if we're going to get to a point where I give you 56 pills or films of buprenorphine per month, I don't want you taking them in the first week. And understanding that patients have come from a place where if they had 200 Norco pills, they probably would not likely be rationed over 30 days. They would likely be consumed much sooner, and that goes into the issue of impaired control. And if I gave someone 56 buprenorphine tablets or films, I wouldn't want them taking them all in a couple of days or a couple of weeks. But the good news is, once you take more than 3 of the 8 milligram strips in a day, or 24 milligrams, you don't feel anything incrementally when you go to 32 milligrams or 40 milligrams or 48 milligrams. So you're just wasting money, number one. You're going to affect the relationship with your prescriber because you're going to be calling for early fills. And in all likelihood, insurance won't fill it early. The pharmacy may be uncomfortable filling it early. So it's best to just find the dose that works, the minimally effective dose to control cravings and make someone feel normal. That's really the goal of methadone and buprenorphine. It's not to get high. It's to feel normal. Because as you know, most people, before they give up opioids, the majority of them are not getting high at that point anyway. They're just on this unfortunate merry-go-round where they have to use to fight off the withdrawal, and they have to use to be able to work or be able to care for their kids, because the withdrawal symptoms are so onerous that that's really what's driving their use and all of their maladaptive behaviors at that point. If it would be stealing to pay for drugs, or prostituting to pay for drugs, whatever you could imagine someone would do to continue using opioids, it's even sadder to know that they're just doing this to be normal at this point. They're not even getting high off these drugs. So my goal of using buprenorphine is really to give them that same normalcy, but without having to do all of those dangerous behaviors. The goal is not to get high. And if you get a patient that is really their goal, then they will likely be disappointed with buprenorphine. Some people will say that methadone can get you high if you get to a sufficient dose. And so there are those individuals who may still be seeking a certain state of mind, or numbness, or buzz, so to speak. And many people who've been on methadone and ultimately end up coming to me and receiving buprenorphine tell me that they were able to get high on methadone. Plus, they can use other drugs, other opioids, and not have their effects blocked, whereas buprenorphine and naltrexone would block those effects. So that's enough on the medication side. Let's move a little forward. On the left is a slide that shows what happens when you use a short-acting opioid. And this could be heroin, fentanyl, Norco, Percocet, for a couple examples. And so all the way to the left, that's time 0. That's when someone takes the pill or injects the drug or insufflates the drug through their nose. Some people call that snorting, but that's time 0. And so immediately you can see that they feel high or they're loaded with the drug. And then they move into that center zone that goes across, and that's the comfort zone, the normal range where you're not overly affected, but you feel comfortable and you're aware of your surroundings. And that's probably, from a drug user's perspective, not a bad place to be. But very quickly, you see that curve start to go down, and they fall into the lower third, where they start to feel subjective withdrawal symptoms, and that's where they feel sick. And there's the subjective withdrawal, where that's just how you feel internally, and then there's the objective withdrawal, and that's where you clearly are in withdrawal. The pupils are large, they're sweaty, can't sit still, have diarrhea, all the objective signs of withdrawal. So that's a 24-hour curve of a short-acting opioid. Now, if you look over to the right, this is what buprenorphine or methadone purports to do. And this is overlaid with the short-acting opioid. They kept the curve there, so you can still see the curve that goes down. But then you see in the middle zone, you see what happens with buprenorphine. You take it, and the effect goes up as it's absorbed. And then there's a very slow decay of the effect. And at 24 hours, you look, and they are still in that normal range and comfort zone. So if you're still feeling normal, you are not compelled to use again because of withdrawal. Now, patients may be compelled to use again because of other reasons. They may want to numb up from some situation, or they may desire to be high again. That's a different story. But in terms of the withdrawal compelling a patient to use, you can see why someone who's on buprenorphine or methadone in the middle zone would not be compelled to use, because 24 hours later, they're still in the target zone. So that's a great advantage to these, the medication-assisted treatment. So why use agonist or partial agonist medications for opioid use disorder? You can look at the patient and community-centered outcomes, such as lower all-cause mortality, lower rates of fatal and non-fatal overdose, lower rates of hepatitis and HIV, incarceration, decreased healthcare costs, decreased acute complications and ER utilization. I'll pause there for a second. In addition to working in the addiction field, I work as a hospitalist at Lutheran General. So I care for patients that are admitted to the hospital, and that could be for overdose. It could also be for heart attacks, strokes, and typical internal medicine type of admissions. That's really the role I play there, is more of the hospital internist. But I work very closely with the emergency departments about ER utilization, and we've worked to get our ER doctors certified to prescribe Suboxone, which is buprenorphine, so that if they see a patient who is in opioid withdrawal and has opioid use disorder, they can treat them immediately and mitigate those symptoms and then refer them to treatment. Whereas in the past, they would get admitted to our hospital and spend days getting detoxed off of the opioid without really anything for cravings, and then discharge them without any protection. So you go home with cravings and no protection unless they've agreed to go to an inpatient program or partial hospitalization or IOP, where they have structure that can hopefully keep them on the road, the right path, but they'll be there without protection or medication for cravings. So the ER doctors now are prescribing Suboxone, which I think is a great thing, and has decreased the patients that we would previously have called frequent flyers coming back to the ER, those patients that really stress a busy system, where the ER docs are too busy to have that destigmatizing conversation that this is really opioid use disorder, and instead just give them a couple pills and send them on their way, or send them upstairs to a hospitalist like me, where now I get to be the one to have that difficult conversation. And we're seeing 20 patients a day and probably too busy. So that of course has changed, and now we've made it a priority to have those conversations regardless of how busy we are. But the idea is that if they're on an agonist or partial agonist medication, they're hopefully not visiting the ER seeking pain pills in the first place, or overdosing. So those are obvious effects. Going back down the list, for pregnant mothers who are opioid dependent, their babies are born with higher birth weight and lower preterm deliveries because they are kept on buprenorphine, but done so in a very monitored way. And because the mother is not either overdosing or withdrawing because of good medical therapy, their babies do better. Patients who receive agonist and partial agonists have increased employment rates. And hang on a sec, I have to move my screen a little bit. Other outcomes include increased retention and treatment. That's very clear, that when you have a patient on medication for cravings, they stay in treatment longer. And we see negative urine drug tests, which is not the be-all, end-all, because if I don't see a negative urine drug test, I don't believe that I'm failing or that the patient is failing, and that moves more towards a harm reduction conversation, but perhaps the patient is using less days per month, which is a win, or using a lower amount, which is a win. Moving on. I'm not going to go too far to interpret these graphs that have squares and diamonds and lines on them. Since I don't have the article in front of me, I can't tell you exactly what each of these boxes represent. But on the left are those who are in treatment, and you could see that their mortality is lower. Because if you look at the x-axis along the bottom, you could see mortality rates. And where there is blue, that means patients are in treatment with medications such as methadone and buprenorphine, and they have lower mortality rates versus those outside of treatment. And over on the right, these are just sort of a meta-analysis of multiple studies showing the effectiveness of methadone in this example in reduction of mortality. This is a graph that shows you that when patients are maintained on medications for opioid use disorder, such as methadone or buprenorphine, actually, no, that's not what this shows. This is talking about buprenorphine tapers versus maintenance. And so when I started doing this 5 years ago, insurance companies would approve medication like Suboxone, but they would approve it for 6 months. And there was this mentality that we should be tapering patients off, that medication-assisted treatment should really only be a short-term strategy. But we've now come to learn that patients do very well on long-term therapy, and that should not be discouraged. And so you see on these on the slide, hang on a sec, that the doses below are around 16 milligrams a day, and that's those that were maintained. And then those that are tapered started on around 16 milligrams a day, and you can see within 6 weeks they're down to 10 milligrams, and at 12 weeks they're off. And that causes decreased treatment retention. And so one of the nice things about buprenorphine and methadone is that patients stay in treatment because they're comfortable and they have their cravings addressed and they're having the most normal life they can. And that's why I probably spend an hour a day dealing with myths about substituting buprenorphine for their previous opioid is really just substituting one for another, and isn't it just switching one for another, and shouldn't we be getting off these medications? But there is no shame in staying on buprenorphine. If I had a high blood pressure, if you were taking high blood pressure medications or diabetes medications, could you imagine your doctor coming up to you and saying, your blood pressure is great, now let's get you off of these medications? That's a strange goal. And so it would be a strange goal to treat this disease when they are doing so well, to then yank that supportive medication out. I have a 95-year-old who is on Suboxone. She's on it for chronic pain. I never put her on it myself, but she was put on by someone and found her way over to me, and she's doing well. She must have had issues with short-acting opioids and withdrawal, and either feeling suboptimal or having maladaptive behavior or something happened, that Suboxone entered into her life and she's doing well. I have patients who've been on Suboxone for more than 5 years and have very full, productive lives, and I would be hard pressed to justify pulling that medication away. It's just an effective medication for a disease, just like their diabetes meds and just like their high blood pressure meds. So this is a buprenorphine in primary care slide, and you see two things here. You see that over 12 months, that patient retention, which is the pink, they had 250 patients at the beginning, and after 12 months, only 150 patients remained in the study, which is still 60% over 12 months, which I think is excellent. But if you look at the percent negative opioid urine screens, it actually goes up. And I think that what happens is when a patient first attempts to give up their opioid that they were abusing or dependent on, it sometimes takes a while to build confidence. It takes time to heal. It takes time to build up strategies to say no to cravings and to remove contacts from their phone, and or maybe even try using other opioids and see that when you're on buprenorphine, they don't work, because as I explained, buprenorphine is like the key in the lock. A second, I realized I'm tilted here. So it's like a key goes into a lock and then you break off the key. So if Norco comes by and tries to get in the lock says, sorry, I got a key in here already. And same thing with heroin, same thing with fentanyl. And so it takes time to build confidence. And you see that 80+% of these patients have negative urine screens at 12 months, which is superb. And you just can't get that without the meds. And so I am all for a concomitant therapy structure. If we can get them into IOP, PHB, if we can get them into residential, if that is what the assessment suggests that they need, and that they would do best with that level of structure in concert with medications, then I'm going to absolutely encourage that. But you could see that the medications themselves are quite effective.
Well, thank you so much, Dr. Kushner, for joining our webinar. I know that it was last-minute request, and I think that from the looks in the comment section, people really appreciated your expertise and experience. So I really hope that many people left with more understanding as well as follow-up resources. I don't see any other questions from those who are still part of this webinar, so I'm going to assume that we are finished. I would like for everybody to be reminded that if you email to be part of this webinar, you will receive a follow-up email within the next week or so with links to the PowerPoint in addition to the recording. And I will also see if we can share the chat as well, because a lot of great resources were shared in our chat, as always. Yes, any final words from both Laura and Dr. Kushner?
I appreciate the opportunity to speak, and hope you guys have a great day.
Thank you so much for attending. If you need any harm reduction supplies, please reach out to Live for Lally, and we will be happy to get them for you. And thank you for all the great comments. This is really, these last 3 weeks have been incredible to be a part of. So thank you for letting me in your lives.
Have a good day.
Yes. All right, everybody. So be aware that we have 2 more webinars during the month of September. Please visit cpydcoalition.org, where you registered for this webinar, to learn about the other 2. With that said, have a great day, Laura, and everybody else. I wish you a great day too. Until next time.
Thank you. Be well.
Bye.